Good evening, Dr. Jay.
Good evening to all present on this Zoom dais as well as all audience. At the onset, I am very thankful to Divya Prabhat sir for giving this valuable time for this our subspecialty ENT session today on the Maha level, and it is our very, I can say, prestigious event of subspecialty, and we are blessed with very much good speakers previously also. So, Dr. Samir, are you there?
He has not joined Dr. Jay.
Okay.
Dr. Jay, we acknowledge the presence of Padma Shri awardee Dr. Kukral Lakna sir from Raipur. So we can have, before we start, Jay, Samir is not there. Yes, Jay, go ahead.
Okay, so I have a pleasure to introduce our today's guest speaker, Dr. Divya Prabhat sir. He's a MS DOR and DNB FICS. He's completed his undergraduate postgraduate study from the GS Medical College, KM Mumbai, and is a trained in the ENT surgery for deafness from Germany, and done cochlear implant training at the Royal Australian Hospital, Melbourne. He is author of 4 ENT books, Practical ENT, and has published almost 41 articles in various international national journals, and almost delivered more than 400 guest lectures and all over CMEs, and is author and editor of the ENT section of IIP book of pediatrics and even adolescent medicine, and has a textbook on the tropical allergy and asthma also. At present, is the head of department of ENT department at the Wadia Children's Hospital, consultant Jaslok and Rahej and Bhatia Hospital, and so forth. He was the president of the Association of Otolaryngologists of India, Mumbai 2000, and is nominated as a top doctor from 2013 to 20 ENT by the India Today. So I request this Divya Prabhat sir to he can start his presentation today, sir.
My dear friends,
Hi.
It's a real pleasure to be with you all during this session. I'm sure the discourses given during this session would be need-based and problem-oriented, and which many things we do not know. We really want to know. I'm sure this session will be great learning, and I have joined this session to learn. Thank you so much for the invitation and for the words to me. Thank you.
Some network issue, audio issue was there, sir. To all the knowledge, to all the info, for the information of all, Dr. Kukral sir had given an oration at our Mahapedicon 2021, which was held at Alibag at Prakriti Resorts, and he had a very good oration given at social oration given to us. Yes, Dr. Divya sir.
Thank you, Dr. Bhandarkar and Dr. Hemant Gangulia, my college friend, and very nice to be back with our friends from IIP. I've been associated for nearly, I think, a quarter century, with all the academic books and pedicons and all, which I've attended. Really it's a pleasure, privilege, and of course my honor to be associated with IIP. So I think you're scaring the screen. Yeah. So again, as Dr. Gangulia said, am I audible? I should ask the first sentence.
Yes, sir. Yes,
okay. Absolutely.
So we go ahead. So we'll be basically dealing with the year in this scenario. Now, when we talk of the year, unfortunately, we only mean the outside year. So whenever anybody talks of the year, it is only the outside year. But what actually happens inside and what you can know from your day-to-day diagnosis, we'll just briefly go over. Now, this is the invite actually which we had, and this itself will convey to you that the otoscope should not be held like that. The pinna has to be pulled in a different manner, and the hand should not support the head in this manner. So there are certain small things which require to be done as far as even using a simple otoscope. So these are the common things. I mean, even if you see the net and all the either clip arts or the emojis, all of them show you the picture, which will not really show you the eardrum at all. So we'll just briefly go into all this. Whenever you see a patient of the ear, it is not a patient of the ear. It is a patient of the ear, nose, and throat. And to know this, you have to think of the ear, nose, and throat as a structure, a hollow tubular organ, which is obviously not seen. And when you think of this tube, it will make you realize that patient with a ear discharge will not stop unless you treat the allergic rhinitis, unless you treat the adenoids, unless you treat the tonsils. So there is nothing like a ear case as far as ENT is concerned. And most of the times, the ear will be made dry. The ear will heal only when the nose or the throat is clear. So whenever you are having a patient of the ear, it is mandatory to examine the nose, it is mandatory to examine the throat. And considering the eustachian tube, it will give you an idea that all three of them are connected by this structure. I think there's some disturbance. Okay. So basically, I just want to tell you, like this is one of the patients which I recently saw, and it was sent by one of our pediatrician colleagues. I was so happy. He was from Ghatkupar. I remember this pediatrician. And he sent me this child that you should test the hearing of this child, and I would want to know. So just a blue sclera, and he thought of Van der Waals syndrome, and he knew that it will be associated with osteogenesis imperfecta or otosclerosis. So therefore, spot diagnosis, knowing that the hearing loss will be there, even though conductive, was very important, and it was diagnosed by our pediatrician colleagues itself. So very important that when you examine children for ENT, the child has to be always held properly. The child has to be held firmly, otherwise examination is not possible. Always one hand of the parent or the staff should be on the head. One hand should hold the child's hands, and the legs should be crossed between the legs. So classically, whenever you're doing an examination, this requires complete immobilization of the child before your exam. Now, what happens that parents will get the child and say that the ear is not there or ear is absent, and they are baffled at this. So you may see children with a deformed pinna. So this is basically a first and the second branchial arch development anomaly, as you know, where the pinna fails to form because it forms from 6 different hillocks and they come together and form the pinna. So what you require to do in such a case, if the pinna is not formed, first thing is you want to know whether the cochlea is developed or not. And for that, a CT scan is mandatory. So get a cochlear CT done, and that will show you the 2, 3, 4 turns of the cochlea and development you would know. Secondly, whether the auditory nerve is normal. So a BERA is advised to detect the auditory pathway is formed or not. Whenever there is an abnormality like this first and second branchial arch development abnormalities, the other congenital anomalies also should be examined for, because they may be associated with, they may be syndromic children where they may be associated with some other abnormalities. And when the parents come to you, their always worry is that the ear should look normal. But it is important for us as a pediatrician to emphasize to them, to counsel them that the priority is to correct the deafness of the child. Well, cosmetic correction can wait, and cosmetic correction is always done at a later stage, normally by the age of 11 or 12 years. So hearing is what is to be looked for and all the cosmetic correction or correction of the pinna should wait for future. So normally you'll just be asked that when do we correct it? The correction is done normally after the age of 11 or 12 because the rib cartilage is very soft before that. So that forms the basic shape of the pinna. The 6th, 7th, 8th cartilage is taken and the pinna is formed and which is introduced into the ear. This procedure basically takes about 6 months. It's not a single stage surgery. It's a 3-stage surgery and the pinna is formed like an adult pinna. Other thing is children may come with ear bleed. The ear bleed is that they may introduce certain things into the ear like a bud, pin, stick, etc. And there will be blood-stained discharge that you see. Other thing, there could be even some disease which is causing blood-stained discharge like granulations or a cholesteatoma, which is an unsafe ear or a ear polyp inside. So first thing is that avoid any instrumentation. Do not try to clean the blood which is there in the ear canal, because moment you try to do it, the bleeding will further increase and one may introduce infection into the ear. Secondly, this bleeding never causes a problem. It will stop just by putting a cotton plug into the ear. And worst come to worst, the best thing would be if you keep gel foam in your clinic, a small piece of gel foam is put in and that acts as a hemostat and the bleeding stops, which is obviously absorbable. It's an inert material. You do not require to remove it. And whatever wound or etc. is there heals well. So ear bleed is to be managed by not trying to clean the blood, not trying to do any instrumentation. Let the blood be there. Let it clot on its own, because by trying to clean it, we may cause more amount of injury. Now, in front of the ear, there could be an opening, which is the pit and what we call a preauricular sinus. This preauricular sinus also is a congenital abnormality. Whenever you see it on one side, examine the other side also, because quite often this is there on both the sides. If there is no discharge, you need not do anything. Only thing is, if it forms an abscess, then it needs to be drained and the surgical excision of the tract is required. But we have a lot of patients who have throughout their life had a preauricular sinus and nothing has been done, and really it doesn't require anything to be done since it has no connection with the middle ear or the inner ear in any manner. Then this is the infant, like, some of them have the habit of putting in oil into the ear, and very often we see them landing up with furunculosis. Furunculosis is where the child comes with severe pain in the ear. You start with anti-inflammatory agents and usually it clears up. Typically it occurs with putting in oil into the ear canal. Antibiotics are given only if the child is febrile, and a drainage is done if it forms an abscess. So furunculosis of the ear. Then there are certain ear tags which may be seen preauricularly. You can see certain ear tags. And these ear tags, again, they are not communicating with the middle ear or the inner ear. So these ear tags can be left alone. If parents need to get it removed, surgically we remove it. But the removal of these ear tags is only of cosmetic value. The other thing is that children in school, while playing, they fight or they have various games and they come with a hematoma. So this is a hematoma where the perichondrium gets lifted from the cartilage and there is collection of whatever blood or serous material inside this. And this is a seroma or a hematoma. Only thing is, if a hematoma is to be drained or aspirated, very important, do it in absolute sterile conditions, because we have seen that, people put in a needle and aspirate and then it gets infected. Once it gets infected, the chance of perichondritis is very high and it leads to a cauliflower ear, which means that there is the shape of the pinna gets affected. So if at all hematoma does not drain on its own, does not clear, one should clean it up very nicely in aseptic conditions. One should drain it. And after drainage, a tight dressing is mandatory. Otherwise, recurrence is the rule for this. The pinna again being an external structure, falls, injuries and all do occur. But moment there is an injury, immediately it has to be sutured, because the moment we wait for the wound or delayed, that can result in again infections and collections. Now, wax is a normal collection, as you know. It is a secretion of the sebaceous and ceruminous glands with exfoliation of the epithelium. So it is a natural collection in the ear, and whenever you see wax in the ear, it need not be removed. Wax is a natural secretion and basically should not be touched, should not be removed. As the ear forms wax naturally, it throws off the wax also naturally. There is a natural centrifugal force that occurs following chewing, where the TM joint hits on the ear canal and throws off the wax. So wax forms naturally, it is thrown off naturally. It has a lot of antibacterial properties. Whenever we see wax, we do not see infections in the ear. We do not see infections, so it has a good protective mechanism also. And lastly, the earbuds always cause impaction of the wax. So avoid using earbuds so that the wax would get impacted. It would not benefit the ear. Probably it will only benefit Johnson & Johnson. You do not require any vehicle to remove the wax. The wax forms on its own, comes out on its own. So no external vehicle is required to remove the wax. The thing which we can do if the child is complaining of ear blockage is one can do syringing. Now, to do syringing, just remember that this should be always done in the sitting position, not in the lying down position, because the ear has a branch from the vagus nerve, the 10th nerve. If the vagal stimulation occurs, the child may get a vasovagal attack, and if he's doing it in a lying down position, we'll be totally unaware of this. In the sitting position, when the child slightly feels giddy and all, you can stop the syringing. But in the lying down position, it may become too late. And secondly, the water that is to be used should be used at body temperature. One should not use hot water. One should not use cold water. This leads to a caloric-like reaction, and the patient will start throwing up or vomiting if it is used. So the best way is you don't require a thermometer or anything to put into the water. You can put your own finger, and if you feel that water is tolerable to your body, then it is fine for syringing. Now, the procedure of syringing is never syringe directly into the ear canal. Always it has to be in upward or backward direction. Because if you try to syringe directly on the wax, or if a foreign body is there, you will push it further inside and the wax will never come out. So always the direction has to be upward and backward. And after the procedure, one requires to dry the ear, because water remaining inside the ear will lead to other sorts of infections at a later date. Then you have children who will come with ear discharge. We have to decipher whether this discharge is from the external ear or from the middle ear. Fortunately, the inner ear does not cause any ear discharge. So you have to decipher between the two. Whenever it is otitis externa, the ear canal will be inflamed. You can see that there will be edema around the ear canal. And when you move the pinna, this movement is very painful. So painful movement, inflamed canal, means the discharge is from the outer ear. If it is otitis media, the ear canal will be normal in size, no edema, and when you move the pinna, it is painless. The pinna being a single yellow elastic cartilage, which is continuous with that of the external canal. So whenever you pull the pinna, and if the canal is inflamed, it will be painful, which is classical of otitis externa. Now we'll just come to the basic of ear mechanism of hearing, which
It consists of 3 sections: the outer ear, the middle ear, and the inner ear. All 3 sections work together to deliver sound to the brain. In normal hearing, the outer ear picks up sound, which it sends in waves down the ear canal to the eardrum. These sound waves cause the eardrum to vibrate. The vibrations cause the tiny hair cells inside the cochlea to move. The hair cells absorb the movement and change it into electric impulses, which it sends to the hearing nerve fibres and to the brain. This becomes sound.
So this is the basic mechanism how sound gets into the inner ear. So all the sound which comes from the tympanic membrane goes via the ossicles into the inner ear. So what is coming from outside is called as air conduction sound. And the other type of sound which we hear is directly from the bone, directly into the cochlea, and called as bone conducted sound. So air conducted and bone conducted sounds are what actually are we require to test. And these will give us the basic condition of the ear itself. Now, what you should do is in the clinic, all of you have a tuning fork, strike the tuning fork, place it on the mastoid, and if the sound is not heard, transfer it in front of the external auditory canal. As you transfer it in front of the external auditory canal, if the sound is heard better, it means Rene's is positive and there will be practically a normal hearing, or it may be a very severe sensory neutral. So there are two types of sounds which you have to decipher with the differences between air conduction and bone conduction. For bigger children, that is usually above the age of 5 years, since we require their concurrence to do the test, we do the pure tone audiometry. Pure tone audiometry will tell us whether it is a normal hearing, mild, moderate, severe, or a profound type of a hearing loss. So typically the different forms of hearing loss that we find will be in the external ear, if in the middle ear, it is called a conductive loss, and the commonest causes will be wax, fungus, or otitis externa. If it is a sensory loss, it is the cochlea which is affected, and it could be a neural loss where the auditory nerve is affected. So these are we decipher it as conductive or sensory neural, and if both are involved, we call it a mixed hearing loss. Now, very important for us is visualizing the eardrum. And to visualize the eardrum, the otoscopic examination is a must. And this otoscope, which all of you have in the clinic, just few words how one requires to utilize it. Now, for visualizing the ear in a child, the pinna should be pulled in a downward and backward direction. What this does is that it makes the external canal, the cartilaginous part and the bony part in one alignment, and therefore it gives easy access to visualize the eardrum. So first thing is pull the pinna downwards and backwards. Second, when you're using an otoscope, the back of the palm is rested on the child's face, so that if the child moves in front or backwards, the ear speculum will not damage or will not hurt the child. And by doing this, you can use a right size speculum. If the canal is too small, use a smaller speculum and you would visualize the eardrum. So this is the method of seeing the eardrum in children. Now, one of the very common conditions that we see following URTIs is acute otitis media. Acute otitis media is inflammation of the middle ear and the bulging drum. Now, the American Academy of Pediatrics places acute otitis media as the commonest cause of admission of a child at night. So a crying child at night brought to the hospital in an emergency, the first cause is acute otitis media. To quote one of your teachers in pediatrics, when I heard him, the sentences I remember, and he said that there is no test in pediatrics that tells you that you keep your hand on the abdomen of a crying child, look up to the ceiling, and then tell the parents that this is an abdominal colic. But definitely there is a test where you can take an otoscope, put it into the ear canal, see a bulging drum, and say that this is acute otitis media. So the commonest cause of a crying child is acute otitis media. And the reason for this is that the eustachian tube is short, wide, and horizontal in children. An infant especially spends maximum time in the lying down position, the supine position. The adenoids are enlarged normally also physiologically. Vomitus and milk may block the eustachian tubes. Once there's an infection, we give usually antibiotics, analgesics, antihistaminics to treat the URTI. So this is one of the reasons why AOM, what we commonly call as, is one of the commonest emergencies in a crying child. The other form of fluid which is found in the ear is called as serous otitis media. This is non-infective fluid, non-inflammatory fluid, but one of the very common conditions that lead to future damage. And typically serous otitis media we see in those who have more allergic tendencies, children with rhinitis, allergic rhinitis, land up with this. You can see bubbles also, on an otoscopic examination. Very common is, what we do is put in a grommet for recurrent serous otitis media. A grommet is a tube-like structure with flanges on both sides and hollow in the center. This is not a drainage tube, it's a ventilation tube. It ventilates the tube, meaning it clears this carbon dioxide collected in the middle ear, oxygenates the middle ear, reduces the inflammation of the middle ear, and it opens the eustachian tube. So automatically, it is functionally makes the ear a normal physiological ear. And with passage of time, you can see that the grommet moves to the periphery and it is thrown off with wax. On an average, 3 to 6 months it takes for a grommet to get extruded. The advantage is that it improves the hearing immediately on drainage of the fluid. And many of these children who are diagnosed as LDs, delayed speech, etc., they instantly improve on insertion of grommet. This is a small visual.
Next, a tiny cut is made in the eardrum, allowing it to drain, and the extra fluid is cleaned up. Finally, an ear tube is placed in the opening.
So this is a myringotomy where the fluids are drained. Now, very commonly, you will have children coming with earache or pain in the ear. Why earache is very common? The reason is that the ear is supplied by a lot of nerves all around. You have the C1 and C2, which supply the cervical spine, and they supply the back part of the pinna. You have the fifth nerve or the trigeminal nerve. The trigeminal nerve, which has the dental nerves, mandibular nerves, they again supply the TM joint and also the anterior wall of the external auditory canal. Then we have the facial nerve. The facial nerve also gives a twig into the external canal, and like herpes zoster and all the facial nerve involvement, patient will come with earache. The glossopharyngeal nerve supplying the tonsils, part of the tongue, would again supply the medial wall of the middle ear, and again the children complain of earache. Or there may be lesions of the vagus. Vagus gives a twig on the external canal, and that is again, so all conditions involving the vagus can cause earache. And lastly, the hypoglossal nerve, where the tongue is involved with ulcerations or glossitis, will cause earache. So since the pinna and the ear has got extensive supply from different nerves, so all conditions involving the tongue, the cervical spine, the vocal cords, the dentition, or even acute otitis media, they present with earache. So whenever you have a child with earache and the ear is normal, it's very important to examine the nose, the oral cavity, the neck also, because the cause may not be in the ear, it may be somewhere else which is causing earache. So only analgesics may not be enough. So otitis externa is usually bacterial, and you can find inflammation of the ear canal on external examination. There will be inflammation, there is discharge in the ear canal, and this is typically a fungal infection where you can see candida or white spots, maybe white or black, which is Aspergillus niger. So otitis externa is classically either it could be bacterial or fungal itself. Now, when we come to otitis media, one of the commonest conditions, I mean, as far as the ear is concerned, things we have to remember that otitis media always follows a set clinical pattern. It goes in various stages. It is most of the time self-limiting, clears up on its own. And only thing, if there is an attic perforation, which can lead to complications, we need to treat it as urgently as possible, because it can lead to complications, intracranial complications, which will go in the coming slides. So this is typically, of course, from a book where, I've just shown you that in otitis media, what happens? The eustachian tube gets blocked. The middle ear, there is fluid, causes a perforation. If not treated, it can go into the mastoid and lead to mastoiditis. And if not, if it is an unsafe ear, it can go intracranially and affect the various intracranial structures. This is one of our articles on otitis media where we had done a review, and classically all India review, where there was flattening of the middle ear fluids. And this is just to show you that one of the US studies, that otitis media, the incidence, with this you can just imagine the incidence in children. The incidence is 5 to 7 million, while for meningitis it was 1,400. So the amount of population, children affected by otitis media is so high that it is probably missed or it is overlooked, and therefore later on they come up with complications following otitis media. So about 80% of the complications are complications following otitis media, which is not probably treated in time. So this is a normal middle ear, and here how the middle ear gets filled with fluid as the eustachian tube is blocked and the eardrum is bulging. You can see it on otoscopy. When you just put in an otoscope, you'll see a bulging drum. So what happens if that otitis media has not been tackled immediately? It leads to a perforation, and that perforation we call a central perforation. So this is a central perforation, which means it involves all the 4 quadrants of the tympanic membrane. Central perforations, patients or children come with profuse ear discharge. It's always odorless, like mucoid, associated with always respiratory tract infection. They say that we got a cold, and following the cold, this discharge increased. Antibiotics, antihistamines are given. If we give antihistamines, and small perforations always heal on their own, but only larger perforations require a tympanoplasty. So small perforations this is self-limiting. So even sometimes moderate perforations also can close, but only large or subtotal perforations require closure. The X-ray that is advised for otitis media is a Schuller's view, and typically you can see in recurrent otitis media, there are absence of air cells. Absence of air cells are indicating a chronic otitis media. Now, same thing is when you see in a normal mastoid. This is a Schuller's view with a normal mastoid. You see air cells in the mastoid, and these air cells indicate the mastoid is normal, so the middle ear will also be normal. The second type of perforation which needs to be one needs to be worried about is called an attic perforation. Attic, as the name suggests, it is on the roof of it, or you have to tilt the otoscope at an angle to see the roof. So when the attic area is involved, this is usually associated with a cholesteatoma, and this cholesteatoma damages or destroys the underlying bone, causing intracranial complications. X-ray shows destruction, there will be a mixed hearing loss, and treatment will be a mastoidectomy because only a tympanoplasty would not suffice. Now, typically, if there is a cholesteatoma, one would see destruction even on an X-ray, and this is typically how it will be different from you saw a pneumatic one, you saw a sclerotic one, and now you see a cavity inside. So the cholesteatoma has destroyed the mastoid. So this is a cholesteatoma which can be very well picked up otherwise with a CT scan. So now you can decipher the difference clearly. You can see a pneumatic mastoid on the right side, and on the left side you can see disease or cholesteatoma, and you can see absence of the pneumatization on the left side. 3 forms of mastoidectomy are done. Either it may be simple, radical, or modified radical. Then, as far as complications are concerned, unsafe ear, if the child comes with severe pain in the ear, and if you see that the pinna is shifted outwards, this shifted pinna occurs because of the abscess. The post-oral groove of the ear is always obliterated, which is bulging, which is very tender. Here we require to drain the abscess and do a mastoidectomy at a later date. The complication which is commonest with otitis media, the intracranial complications, is facial paralysis. Facial is the commonest nerve to be affected because in 50% of the children, that high, up to 50% of the children, the horizontal part of the facial nerve is dehiscent. And it being dehiscent, even in acute otitis media, can cause facial weakness or facial paresis. So you can typically see the child on the upper one, infant, on the right side, there's facial paresis. The lower one on the left side, there's facial paresis. All these are following acute otitis media. So acute otitis media may cause it, but there can be other causes also. It may be congenital, it may be due to birth trauma, that is using of forceps. It will be Bell's palsy, cholesteatoma. So whatever the cause, we require to treat it. Another complication is, of course, we see it in the elders more of his acoustic neuroma. So I won't cover it over here. So 2 types of perforations we have seen. One is a safe perforation, which is a central perforation. And the second type is a attic perforation, which is a small perforation, scanty discharge, but it can lead to various complications. And the complications that we see could be an extradural abscess, subdural abscess, it could be meningitis, lateral sinus thrombosis, brain abscesses, and hydrocephalus. So these are the various complications that one might encounter. So typically when we see children with fever and the fever is not responding, we have to look out into the ear as a focus of infection. And this focus of infection, with the fever, these are 3 typically complications that we see with cholesteatomas, that with recurrent meningitis, children with lateral sinus thrombosis, or with hypothermia, that is when we suspect a brain abscess. Now we do pure tone audiometry to know what the hearing is of the child. The red color always indicates the right ear, blue indicates the left. The continuous line is for air conduction and the intermittent line is for bone conduction. Both lines together will mean it is a normal hearing. If there's a gap between the two, this is a conductive hearing loss. While if both of them are down, it is a sensory hearing loss. So either it may be normal, conductive, or sensory neural. The other test, which is very important to assess a child, is impedance audiometry, rightly called as emittance audiometry. And this is done, it can be done at any age. We do it in newborns quite routinely. What it tells us is that it diagnoses exactly the middle ear pathology. And one of the most important tests to diagnose, see, this is due to the movement of the eardrum. Secondly, it may be serous otitis media, where you get a flat curve. If there's a eustachian tube block, we get a negative curve. And if there is ossicular discontinuity in the middle ear, it shows a gap. So these are the various different forms of tympanometry that we get. Very useful for delayed speech, LD, etc. for these patients. So these are the results which we see. And just to recap, the normal movement of the drum With serous otitis media, you get a flat curve. This is a negative curve showing eustachian tube block, a small curve indicating ossicular fixation, while a disjoint peak shows us that this is ossicular discontinuity. The other test, which has now become mandatory in most of our hospitals, is called as OAE. Now, OAE is autoacoustic emissions. It tests the functions of the hair cells of the cochlea. Again, a very important test. Always, we do it for every delivery now, but it is basically a screening test. And this screening test takes just 2 minutes and gives us a result as pass or refer. If it is pass, then you know that the hearing is normal. If it is referred, then after 3 months, we repeat the test. This is the autoacoustic emission test. Then if this is referred, and at the second stage, we do a BERA. BERA is again a test which is must for all high-risk babies. The reason is, that the right time, if the hearing loss is detected, we prevent any loss of natural speech development in a child. So typically we get these evoked potentials, and the BERA traces the sound going from the cochlear nerve to the cochlear nucleus to the superior olivary body, lateral lemniscus, inferior colliculus, medial geniculate body, and to the brainstem. So typically we get 7 different waves, and we know where exactly the site of the lesion occurs. Now, in a small review, just you'll get an idea why it is so important. Is we had in one of our studies that, of course, we only tested the high-risk babies, but 41% of them had a hearing loss, but only 3.1% had complained of hearing loss, and they were put up as idiopathic developmental delay. So the incidence of hearing loss is much, much higher than anticipated. Now, as far as the auditory pathway of children is concerned, it is formed at birth, but by 6 months you find it totally complete. But for this completion of the auditory pathway, there is neuroplasticity. It is a very plastic type of, it changes with every month. And what happens, I'll just briefly tell you, which will give you an idea as to the importance of hearing sound. Now you have the cochlea, which is the organ of hearing. You have the inner hair cells, the outer hair cells. And from the cochlea, the sound energy is converted to electrical energy, and it goes to the auditory pathway to the brainstem. And when the sound goes up, in the brain you have 2 centers. One is visual center, and one you have the auditory center. Now for the auditory center to mature, to form, you require sound. It is like ice. It has to be thawed, and unless it is thawed, that will not form. So what happens that if the auditory center is not formed, then these pathways will not be. If sound is not coming to the cochlea, no sound is going to the brainstem, the auditory center gets taken over by the visual center, and the auditory center does not develop. So there is a loss of the auditory center, and this auditory center gets covered by the visual center, and the child loses natural hearing for life.
A cochlear implant helps people with severe to profound sensorineural hearing loss or nerve deafness. A cochlear implant has 2 parts, an internal part called the cochlear implant and an external part called a speech processor. The speech processor has a small microphone which picks up sounds, turns them into signals and sends them to a transmitter. The transmitter then sends the signals through the skin to the internal implant. The internal implant converts the coded signals into electrical energy and sends them to the electrode array. This stimulates the nerve fibres in the cochlea, and the signals are recognised by the brain as sound.
So this is the cochlear implant, a schematic representation, and where the hair cells are absent, no electrical energy is stimulated, and the implant array throws in this electrical energy to stimulate the nerves. This is how the implant is in place. The implant, this is of our children whom we do at Vadia, and now he's of course gone to 12th standard, this boy. And if the children do not have hearing, have a hearing loss and they're missing out in school, it is important otherwise to fit them with a hearing aid. The hearing aid will at least tide over the crisis, natural speech development will occur, and the hearing centers in the brain will remain normal. So for natural development of speech, it is important that for the first 5 years or maximum up to 7 years, where the natural speech is developing, sound stimulation is a must. So whether it is acute otitis media, whether it is putting in a hearing aid or a cochlear implant, stimulus with sound is necessary. It is either use it or lose it. And once lost, it is lost for life. So for natural speech development, that becomes important for an active child. Now, there is no reason of a disability because nowadays children all use, many of them use Bluetooth, which is not only bigger, it is 3-4 times bigger than a hearing aid itself. So typically what we have seen that the sequelae to ear discharge or otitis media is a perforation. So it may be a moderate size perforation that you may see on an otoscopic examination, or it may be a total perforation. If it is moderate size, one can wait and give it chance for it to heal. But if it is a total perforation, a ear closure like a tympanoplasty is mandatory. Many a times when they have smaller perforations, it heals and you will see a whitish discoloration on the drum. This whitish discoloration is because of tympanosclerosis. It is a healed drum. Nothing need to be done for it. Secondly, whenever you're seeing, you may see an intact drum, but there will be scanty discharge. There will be foul smelling discharge. Always tilt the otoscope higher up and you will see a small pit. A small pit is because of an attic perforation. This is otherwise missed unless the otoscope is tilted and we see towards the roof of the ear. And this pit, if it is missed, it can lead to cholecystoma formation. It destroys the underlying bone and it can cause intracranial complications, facial paralysis, as we had already seen. Now, we have learned that if there is otitis externa, it will always be painful because the ear canal is continuous with that of the pinna. If it is otitis media, it will be a painless condition. Now, whether to use drops or not, as far as otitis externa is concerned, avoid using combination ear drops. Combination ear drops, we mean that many of the drops available in the market are like the masala drops. It is, they call it antibacterial, antifungal, analgesic, anti-allergic, local anesthesia, everything. So masala drops should be avoided. If it is fungus, use antifungal drops. If you want to clear wax, use wax dissolving drops. If you want to use for pain, you can put local drops, but avoid using combinations because most of the time what may happen that for otitis externa, bacterial, you use combination drops and finally the child lands up with otitis externa fungal. So bacterial will become fungal and they do not really improve when you're using these combination drops. Secondly, if it is otitis media, whether to use drops or not. Minimal use of drops, because in otitis media drops, ear drops have practically no role to play. The drops that you use, first of all, will not reach the middle ear through the perforation because you are not going to clean up the middle ear under a microscope and send the child for using drops. So the drop, since the middle ear is filled with discharge, the drops will not reach the middle ear. Secondly, if they reach the middle ear, they will open the lateral end of the eustachian tube, while we want the medial end of the eustachian tube to open. And thirdly, many of the drops, like you have gentamicin, kanamycin, all these drops available. So many of them are ototoxic also. So they can percolate through the round window, oval window, causing some amount of a permanent sensory loss. So use combination is avoided. Minimal use as far as otitis media is concerned. Whenever you have a child coming with ear discharge, not to worry, it all clears up. But if a child of ear discharge comes with headache, fever, vomiting, blurring of vision, any signs of raised ICT with giddiness, visual disturbances, you have to think of intracranial complications. That time, tertiary referral or a MRI or a CT may become mandatory. So use an otoscope regularly. visualize every normal ear. Once you have seen normal ears, it is very easy to pick up abnormal conditions. You may see a normal eardrum, you may see acute otitis media or a bulging drum, you would see fungal infections, or you may see some trauma because of instrumentation or some injury. So important is stimulation, sound stimulation in the children. Always test the hearing. Whatever age the child is, hearing needs to be tested as early as possible, because either you use it or lose it. Thank you for your attention. Thank you, Dr. Hemant. Dr. Bhandar.
Thank you, sir. It was I think almost covered all the spectrum of the disease that we pertain to pediatric ENT. There are a lot of questions in the chat box. I will go one by one. Dr. Samir is asking, sir, you said wax is protective. So when to remove the wax? Specific indication to remove the wax?
So you will see wax in every child's ear. You are not going to remove all the wax unless they come with earache, ear blockage, they come with symptoms, or you find it totally, impacted as such. I mean, it is better to not to touch it, because some amount of wax will be there in every ear. Better not to remove every wax unless they complain or they come with, there's a hearing loss, etc.
Okay. Dr. Jayan Pandey, past IP president, asked Maha IP president, sir, how to classify small, moderate, and large perforation? Whether it is specific sizes are there or is the clinical judgment?
Yeah, basically, a large perforation is one where there is no peripheral drum remaining. Meaning there is no eardrum or tympanic. It's 10 millimeters by 8 millimeters normally. I mean, that's the size. There's no peripheral margin. Yeah. That is a large perforation.
Okay.
Moderate perforation is you see a margin all around it. And small perforation is one which is there in either one or two quadrants.
Okay.
The moderate will be there involving all four quadrants. So that deciphers whether it is small, moderate, large.
Okay. Dr. Yasmin want to ask the proper way of examining external canal and things to be noted. Can you elaborate on this?
Okay. So whenever you are watching the, you have to watch the tympanic membrane. In children, typically below 3, you should pull the pinna downwards and backwards. That will bring the external canal, cartilaginous and bony part in one alignment. So first thing is you have to pull the pinna downwards so that both come in one alignment. Second, when you are introducing the ear canal in the speculum, it should be of the proper size. It should not be too large as far as the canal is concerned. It will be very painful otherwise. When you see the drum, you have to first see for the cone of light. Normally in the anterior inferior quadrant, there is a cone of light. And when you see a cone of light, you know that things will be normal inside.
Okay.
Because the eardrum is at an angle of 55 degrees from the horizontal. The superior part of the canal is smaller and the inferior part is longer. So it's at an angle. When it is an angle, then all the light gets concentrated in the anterior inferior quadrant. So if there is fluid inside, that light is lost.
Okay.
If it is retracted, the light is lost. And if it's a perforation, obviously you don't see it.
Right.
So most important is seeing the cone of light.
Right. Okay, understood. Dr. Saviri, if OE is normal, do we still need to do BERA in the patient?
No, if OE is normal, rest assured things will be normal.
Okay. Okay. So there is no question in the chat box. Anybody want to ask the question?
Dr. Jay, I want to ask one thing.
Yes, Doctor.
2 or 3 things, sir. The thing you said, ki, because in one of the things I have seen, you said ki when there is a bleeding, you have to put the gel foam or the cotton to just stop the bleeding. But does one should examine for the and any other things inside? Because in one of the patient, it was only 3 or 4 months old child and was brought with excessive crying and just blood coming out of the ear. And just when I happened to see that ear, there was maggot inside. And so whether at all bleeding, we should see something is foreign body or some, and that maggot then I removed with the help of this putting the saline and then slowly suctioning the things. Of course, suctioning is very has to be done very judiciously, but we can remove that maggot. So is this thing and one more and foreign body? What about this?
Yeah. Now, if they come with bleeding, they're very important that don't do anything if there's active bleeding. Because see, you don't have a microscope and you don't have those micro instruments. Because if you introduce anything blindly, one can cause more damage than do good.
Yes, yes.
So I would suggest there is no emergency. Let the bleeding stop. Once the bleeding has stopped, next day, next to next day, you can comfortably. Once it is dry, you will be able to do everything properly. Because if there is active bleeding, you won't be able to see anything. And you will cause more damage. The drum will come out, the ossicles will come out, damage. The damage will be extensive.
तो मैगट रहेगा तो भी उसको ऐसे छोड़ देने का क्या?
छोड़ अगले एक दिन के बाद बुलाने का.
अच्छा, कुछ नहीं होगा.
हाँ, कुछ नहीं होता यार. Nothing happens.
Sir, I have one question. When you talk about, when you say patient of URI, right? And patient came with patient of URTI, then he came with pain in ear. What is the age of cutoff line, whether I should bother to start antibiotic or not? Can I wait, whether it is the exact demarcation of the age in the pediatric ENT, right? By suppose patient is 4-year-old, I can wait. Suppose patient is 1-year-old, I should start immediate antibiotic. How I should go about it?
Usually, if the patient is febrile, we find purulent postnasal drip is there. Or if you see the nose, you find the middle meatus, there is mucopurulent discharge. The drum is bulging and looks absolutely red. So age is not the criteria. It's not that one size fits all. You depending on the child's presentation, you will decide on antibiotic. But more important than an antibiotic is nasal decongestant, nose drops, or saline washes. Those things are more important.
Many of patients came with viral ear, right? Mainly.
Yeah.
They came with the pain in ear, right? Viral ear, whether they should start antibiotic or should, because some patient has a very clear-cut watery nasal discharge, and viral go with a very high-grade fever initially, it may subside 3-4 days. Suppose patient came with pain ear on first day or third day or fourth day. I should wait. Suppose patient 5 years age, I should wait for to start antibiotic or not. Whether it's patient younger, like 1 or 2 year, right? It is very difficult to decide whether it's pain, the patient is crying due to pain or some other reason. Right. What I should do in that?
Yeah. So see, we use quite less of antibiotics. In fact, in the younger patients, they're actually speaking. That's what I said. You require more of, maybe you can use nasal drops. You can use an antihistamine and supportive treatment like give analgesics, anti-inflammatories. Antibiotics, you need not start immediately, for all. Unless the child is too bad, too toxic.
Okay.
Sir, even the dose is differently everywhere about the antibiotic. Like amoxicillin. Hello?
Yeah.
So dose of amoxicillin also written differently. Some books mention 50 mg per kilo. Some books mention about 90 mg, particularly Western side books. So what do you feel? Suppose you want to give antibiotics.
See, basically in acute otitis media, all the literature shows that you can start with even azithromycin, amoxicillin, amoxiclav, and then you go in for ceftriaxone or cefuroxime. So this is the level how we get about it antibiotics. But there are a lot of papers which show that really antibiotics don't make that much of a difference also. So don't depend on antibiotics too much, for all this.
Okay, so sir, when you talk about the amoxicillin, pneumonia, yes, 50 to 60 mg per kg is sufficient. When you talk of ear, basically 90 to 100 mg per kg of dose should be required. That to be given for the 10 to 14 days. What is the minimum duration of antibiotics? Yes, especially for amoxicillin, is the commonest antibiotic used in a pediatric practice.
I'll tell you. Basically, it should be given for otitis media. If you're giving it amoxicillin, give it for a week.
Okay.
We give it for a week, but antihistaminic or nasal saline drops will continue for 3 weeks.
Okay.
But that is more important to prevent the recurrence.
what is the role of analgesic ear drops? Suppose I have a patient of viral URI giving the pain in ear, no ear discharge, and on otoscope seems to be normal. Whether lot of companies have this typical of only analgesic ear drops, but whether there can be used, what is the role of that in the pediatric practice?
In fact, we routinely use what local is available, local drops, what we call lignocaine, xylocaine, and all. We to regularly put those drops in the ear. What we use for all even surgical procedures, the same local drops we just sprayed into the ear. At least they become comfortable, you know.
They can be used, but you have to confirm whether it is perforation or not. That is very important.
You know, local drops you can put, no? I mean, nothing will happen.
Okay. Even patient ear tympanic perforation, nothing will happen.
Nothing will happen. You put local drops, nothing will happen.
Okay. Thank you. Dr. Hemant, you want to ask something?
Dr. Jay, there is one, Dr. Divya has raised the hand.
Okay.
Yes, Dr. Divya, you want to ask?
You can unmute, start video also, and you can ask the questions. No issue. Please.
Pallavi madam, sarana permission there so they can unmute themselves.
Yes, sir.
By the time that then why that masala drops are available? Cannot our association can make that manufacturer to ban all these masala drops, which contains all things, antifungal, antibacterial. And one more thing, to be precise, one to identify otitis externa. So in that case, we can give some local pain drops. But suppose it's a chronic otitis media, all the time is coming. Whether in that means whether any drops to be given, really drops are required, or only saline. Saline can be used as a ear drops.
Yeah, saline can be used if it will just liquid, but actually serves no purpose. We should use nose drops.
Okay.
In fact, in otitis media, ear drops has practically no role.
Oh. Yes, Dr. Divya,
Hello,
you
good
want
evening,
to ask
sir.
something?
Yeah, thank you so much, sir. It was a very nice session, sir. We got very good information regarding the various diseases. I wanted to ask, sir, in case a child is suffering from viral URI and subsequently he starts complaining after a few days of blocked ear on one side and he can hear his voice more on that side, but there is absolutely no pain. So in that condition, what is the treatment that we advise, sir?
Basically, if it is a viral, I mean, you can just give saline drops, you can give an antihistamine, and that will clear up.
That looks like a serious otitis media, sir?
Yeah, absolutely. Serious. Exactly what is. First, what happens because of the mucosal edema, the eustachian tube gets blocked. Then
Yes,
whatever CO2 is there in the middle ear gets resorbed. Then the nitrogen gets resorbed, the oxygen gets resorbed, and that negative pressure causes exudate and transudate collection in the middle ear. So if this does not open, that will lead to serous otitis media. And that serous otitis media later on can cause even a mixed hearing loss or a sensory loss also.
So in that case, sir, how many days we need to wait for going on for treatments like grommet insertion and all?
Grommet is not done on the same sitting. First, you have to treat it medically. If not, we do the impedance audiometry. And if the impedance audiometry is not changing, I mean, you get a flat curve, then only we consider a grommet. In fact, grommet is the second commonest operation in children all over the world, just after circumcision. It's a very common thing done outside, but over here, probably serous otitis media is a missed diagnosis. It's not that we don't have it. Like when I was, of course, lecturer in the medical college, we used to hardly see grommets. I mean, do grommets or whatever. But in private hospital, when we go to our OPDs, we see so much of patients with grommet because they come early and they are diagnosed also, you know.
Sir, there are questions.
Thank you so much, sir. So one more question I have, if there is any, if there is time, can I ask one more question, sir?
Yes,
sir, I wanted to know, we have our many high-risk babies which we follow from an ICU. So in the high-risk discharges, do we need to go in for BERA examination for most of them, or we do OE first and then only we go for BERA?
Yeah, see, basically we used to do it for all NICU graduates and all at our place. But if they are high risk, you definitely should do a BERA. I mean, because I showed you one of our studies where only number of people who parents have complained is so less, but the incidence of hearing loss is so high. So there's a gross discrepancy between the two. So you should do a BERA for high risk, like whatever neonatal jaundice or meningitis on Genta, etc. For them to have to do a BERA, but at the same time, OE is becoming universal. In fact, on 1st of May in Mumbai also, we are starting OE compulsory following every delivery. So all maternity homes and hospitals in Bombay, from 1st of May, we have a program where we are starting. OE.
We are doing that, sir.
Yeah, it's mandatory. It's going to be mandatory even in public hospitals in Bombay now.
Yes, sir. Thank you so much.
Okay, Dr. Lata, you can ask the question.
And then Dr. Chetan.
Yeah.
Lata, Dr. Divya Prabhat invited me for this lecture, and I'm practicing in Evansville, Indiana, for the past 21 years in pediatrics, and it was quite informative, and I was impressed. I do a lot of this. A lot of it is standardized here, like you said, the newborn hearing screen, and definitely do a lot of exams, ear exams and stuff. And we do have a planogram in the office too, sometimes I use. So it was very enlightening lecture. So I have to thank you.
Thank you, Lata.
Review it again for sure, the recording once I get hold of it. But it was very good lecture. So thank you for inviting for me to see it live.
Thank you. Our pleasure. Our pleasure.
The recording will be available on Maha YouTube channel. One can see another again.
Dr. Lata,
yes.
Dr. Hemant, she's from KEM. You must be knowing her. Yeah, in the US. Pediatrics from the US. Yeah.
So this question in the chat box, is the hydrogen peroxide solution helpful for the wax?
Yeah, should not be used at all. Because what happens, hydrogen peroxide generates some amount of heat also.
Okay.
There's effervescence, the nascent oxygen gets generated, and that heat will be damaging to the epithelium, basically. So one should not use, and obviously should not use buds.
Okay.
Dr. Chetan wants to ask. Dr. Chetan wants to ask question.
Okay, Dr. Chetan, go ahead, please.
I want to ask you that does nebulization leads to the ear discharge or something?
No, not at all.
Many patients have complained about that कि हमने nebulization किया and then ear discharge has happened.
That may be a coincidence, because in fact that will probably open it up also, and it will improve the eustachian function. So that cannot cause any ear discharge.
Fine, sir. Thank you.
Sir, any tips for preventing ear infection when swimming?
Yeah, basically after swimming, very important that the ear has to be made dry, either typically with a towel, we tell them.
Okay.
Yeah, you can just dab the towel and the ear gets dry itself. And supposing after a head bath and all, sometimes they say, there is water inside. So I tell them otherwise, if it does not dry up with that, you can use a hair dryer.
Sir, I have one question. When you talk about the chronic otitis media or chronic ear discharge, when should I suspect it is a resistant bacterial infection or some other condition like immune deficiency, other things? Whether it is a duration, when you should call it as a chronic otitis media or chronic ear discharge? What to do with the role of antibiotics? So duration will be the same like acute, but for the long term duration. And where is the role of pus culture also? Chronic ear discharge.
Yeah, see, basically you have to remember that otitis media, chronic otitis media is a self-limiting condition. So most of the time, if you don't do anything also, it clears up. So very important is if you are giving antibiotics maximum for a week and it is enough, we do not do cultures at all, because most of them, they all clear up. You can say 99.9% they clear up. Unless they are diabetics. Basically in diabetics, we find where we do these cultures where they don't respond. And you really speaking don't require antibiotics longer because it is chronic. Once the acute infection is gone, what you require is an antihistaminic, decongestant, nasal clearance. Because all of it in chronic otitis media is coming from the eustachian tube via the nose or the throat.
Sir,
So let us go specifically. Which decongestant you prefer and which antihistamine to be preferred?
All of them are similar.
Okay.
Really speaking, I mean.
So the role of xylometazoline in URI or any.
We use xylometazoline, but to only a very less, of course, we use, but we use it for a maximum period of 3 days.
3 days, right?
Dr. Jay, Dr. Pandrikar sir was there. I don't know where. Dr. Pandrikar sir, you have want to ask? And before he asks, before he says something,
Unmute kara, sir, unmute kara.
We welcome Dr. Pandrikar sir. He was a Maha president for last 2 years. So before he speaks, Dr. Divya, a word about insects and foreign body in the ear. And Dr. Zain sir then after you. Yes. Insects or foreign bodies in the ear coming to the OPD.
Yeah, I mean, if it is an insect which is live, or as you said about maggots also, which you encountered, we just put in liquid paraffin drops into the ear, and they automatically come out.
Yes,
Dr. Sanjay Manthale.
Yes, no, I muted him. Yes, go ahead, sir.
Achha. No, because he's our ENT from Vadia.
Okay.
Sanjay Manthale, that I thought he's saying something.
Okay.
So basically, we just put liquid paraffin drops into the ear, and that is enough, and automatically the foreign body comes out rather than struggling to remove a live foreign body. I mean.
Okay.
And the advantage we have is we usually take the child under the microscope and we use a suction and get it out. Well, if you use a forceps or something, you will traumatize the drum, no? You will traumatize the middle ear, basically.
Pandrikar sir, काय विचारायचं तुम्हाला?
Sir, thank you very much for excellent deliberation, really clearing all our doubts which we face in our practical day-to-day practice. And because, sir, as we are general practitioners for pediatric age group, so my question is to is whether the syringing is safe procedure for us to do in OPD practice.
Syringing
because we are very worried about these vessel attacks.
Syringing is absolutely safe.
Is it safe?
Absolutely safe. And as we just discussed, all the foreign bodies can be removed comfortably. And only precaution is that do it in the sitting position, do it with water at the body temperature, as well as after the syringing procedure, the ear should be made dry. Absolutely. Nothing happens. You can comfortably do, and you can do it with a 10 cc, 20 cc syringe also. And you require tap water. You don't require some sterile water also for syringe.
Sir, I have a question about cochlear implant. Right, the result depends on how early you do it. Suppose my patient is not in a condition to have that because in a costly procedure. Whether it is two-stage surgery is there, some window is I don't know. You can just give some facts about it.
Normally, it can be done after 6 months of age. Of course, the earliest which I have done is 10 months, but 6 months onwards it can be done. As far as you said, I would just like to correct you, Dr. Bhandarkar, is regarding the cost. At Vadia, we are doing cochlear implants at zero cost. We have a scheme from the central government, which is called as ADIP scheme, assisting disabled persons. And patient is not only given the implant free, surgery free, stay free, and 2 years of therapy free, even the parts which are required, consumables, batteries, everything free for 2 years. So it is free to that extent.
Okay. I think that information is more important in today's session because another thing, we miss a lot patient of hearing disability. Hearing asa hai ki aplyala, there is no physical sign as such. And many times we miss it in your day-to-day routine practice. And patient understand a very gross delayed speech, then you go for a hearing test to that. You can have at least give some suggestions to us from the early age, how to at least suspect the hearing disability is there or hearing problem is due to the patient, pediatric patient, because we see patient from neonate to 12, 13 year age, right? Even scholastic backward patient will say, yes, there is hearing problem, we get almost by 7, 8 years. So some facts about that. When to suspect hearing disability in the pediatrician?
Basically, OAE is universal screening is mandatory. And as I said that it is from after 1.5 months, this is going to become compulsory over here.
Okay.
In probably full state of Maharashtra. It's starting with Bombay and then we are doing it for full of Maharashtra. So it is going to be a universal screening. Secondly, all patients coming to the whatever LD clinic and all the compulsory audiogram is done for all of them. We see all of these children. So all the NICU kids, I mean, compulsory, we do all of them a BERA test. So it is a compulsory screening which will detect them, because as you rightly said that they don't have complaints.
Right.
Only 4% have complained, but 50% have turned out to be positive. I mean, imagine the difference is so
huge.
So unless you make it compulsory for them, without that, the child cannot be discharged. Without that, what we are planning is that the child will not get birth certificate in BMC.
Yeah.
That is what we have put in now. Meaning in the last meeting with the commissioner, that don't give BMC certificate unless the OE test is shown to be done.
Right.
Don't give it. So we are introducing things like that,
Yes, Dr. Sanjay want to speak something because Dr. Sanjay.
So whether I think we have completed almost all the questions. And thank you, Divya Prabhat sir, for I think.
One minute. Sometimes we see lots of fungus in the ear, and it really forms a heart. The only ear drops whether any if there is a fungus, whether we have to give systemic antifungals, yes or no.
For fungal, there's no need to give systemic antifungal, but what you require to do is keep an instrument which is like a vectis. It is called a vectis or a ring curate. So when you use a vectis or a ring curate, you can remove the blob of fungus straight away.
Yes.
So doing that is enough. There is no need to give antifungals at all.
But we need to refer to the GMC person, or we should keep it by ourselves? Always the problem.
You can remove it yourself also. It's always outside, the fungus.
Yes.
And if you can remove even majority of it, the rest of it, the drops will take care of.
And sometimes it's very hard. It's very hard. It looks like stony.
Yeah. Because usually what happens, there is wax, and over the wax, the fungus is forming.
Okay.
So once that fungus comes out, then you can start wax dissolving drops, and then that will come out, because fungus will not be hard.
Sir, putting this ritual of putting oil in the ear, whether that causes fungal infection?
No, that causes these furuncles and boils and all in the ear canal. Fungus occurs basically with water remaining inside the ear. Second reason of fungus commonly is using of earbuds, because the earbuds have certain, they have fibers around the cotton plug. So even if some of the fibers get stuck in the ear canal, that becomes a media for the fungus to grow.
And sir, I have a last question from myself. In neonatal age, up to 1 month, sometimes you get a lot of freckles like a ear discharge. Almost is very difficult to differentiate between this normal sebaceous gland secretions or otitis media. So we're always tempted to start the antibody in this neonatal age, which is sometimes very whether some highlight on this.
Basically, this is normally desquamation of the epithelium that occurs in these neonates, and better just leave it alone. Don't do anything. Inaction is the best thing to invest.
Right. Thank you.
Putting saline drops or nasal drops sometimes helps.
Not needed.
I don't know.
Dr. Samir, unmute kara.
Yes, I am listening. I was stuck in the traffic for first 5 minutes. So it was, sorry for that.
So all questions are covered even in the chat box. Dr. Hemant.
So, Samir, thank you very much, Dr. Divya. Samir is going to give vote of thanks and summarize all the things what he wants to say.
So Divya Prabhat sir was my teacher, and I learned a lot of things from him. It's not just the ENT, but like a lot of so many things which I cannot describe right now. And I was very happy when he said yes for the Maha Subspeciality. So we called very senior person who is very knowledgeable and talk about the most basic things. And I am happy that people have learned a lot of new the way they are putting in the chat box. So thanks Divya Prabhat sir for accepting our invitation from the Maharashtra IIP for doing this lecture for today for us. And you have shown a lot of pictures, lot of important things. But I can say to one thing to the ENT doctors that pediatrics today who have seen this much of that so much knowledge that they are not going to refer patients to the ENT now for the small thing what is being expressed to us. So other way around, I will say those people who have missed today, they can watch it again on the YouTube on Maha IP channel. And thanks to Jay Bhandarkar sir for this topic selection of the ENT. And sir was very particular about talking only about the ear, because talking like say nose, throat, and ENT, it's like a very big. People work for 3 years and do MS ENT, so it cannot be possible to finish everything. So we have thought we will do only about the ear part and ear description, particularly related to the otitis media. So thanks to Dr. Jay sir.
Dr. Samir, before you end, I want to just ask, because we practice at periphery, we have very poor patients, and whatever you said, it is all free. But is there any point of contact where we can call up and take the appointment, or when to send to IDEA, or at what place? So they just can go, otherwise they get lost many times, and the precious time is lost.
Yeah. Vadia, we have our OPDs on Monday and Thursday in the afternoon. All the OPDs are in the afternoon. And if it's an emergency, of course, 7 days a week, obviously all the foreign bodies come at any time, of course, from all over the state and neighboring states also. So thing is, but regular OPD for elective patients is Monday and Thursday.
Okay.
And Saturday we have a surgery day. So we do our surgeries, cochlear implants, everything on Saturday, then one day. And cochlear implants and all, everything is totally free. I mean, so if you have anyone, you can avail of that.
Know about this part particularly, because as a working in the Rotary also, we have actually sponsored a couple of patients, but never thought of that way to send it to the Wadi. Actually, we have done it free of cost.
In fact, many people told me, why do you all not, whatever Rotary? I mean, nothing to do against Rotary, but Rotary was advertising this in Bombay.
Yeah.
Why we are not advertising? We were told, many of my friends told me that why are you all not advertising Vadia, you all are doing it free. I said, already we have got such a big waiting list here. Why? I mean,
okay.
Yes, sir.
Presently, 70 patients are waiting for cochlear implant now.
Oh. So how much time it takes for one surgery? Like you do 1 or 2 in a week, or something like what?
Usually one.
1 in a week.
Because we have to fill in the patient's details online to the central body. Then it goes to Aliyavarjang and the central body, and they clear it. I mean, you have to send the CT scan, BERA, and the MRI reports. So they know that this candidate is eligible. So they then send the implant by courier to Vadia, and we operate at Vadia. So that procedure takes about, you can say 15-20 days. So till then, what we do is we do the vaccination of the child. Meningococcal, pneumococcal, typically, I mean, we do the vaccination, and we start with hearing aid therapy, so that they know what sound is, and so counseling and therapy is done with the hearing aid also to prepare the child. So all that is done in the previous month, and then we operate.
Should we conclude, sir?
Yes.
So thank you very much, Divya Prabhat sir. But I know we are going to back to you again and again. Maybe.
Yeah.
Ear is only one part.
Yeah.
Nose रह गया है, throat रह गया है.
I've covered both, right and left ear both.
So right and left leg is there are a lot of like sinusitis, foreign body, and so it's because it's very commonly required. We do wonderful mistakes while treating the patient. So your experience will always enlighten us also how to treat it.
Really,
Thank you very much. I think we got excellent attendance also today, and thank you all the delegates.
Yes.
All for and attend other subspecialty clinics or sessions coming, I think, around the year. Thank you very much, sir. Good night.
Good night.